Hi, everyone. My name is Carolyn Oldham, and I'm the Director of Continuing Education at the Central Appalachian Regional Education Research Center, a National Institute of Occupational Safety and Health CDC-funded center, which is housed in the College of Ag at the University of Kentucky. There we work to engage in culturally informed and responsive research, education, and programming to ensure the health and safety of our workers in our region. Today, however, I'm going to present to you my dissertation research, Unboxing the Japanese Sojourning Mom's Pediatric Going Experience, a phenomenological study of culturally and linguistically appropriate health services. I say that this research was born over cups of matcha and mugicha. It sprung from within the homes of Japanese sojourning mothers who sat down across from me after tutoring either them or their children to ask me questions about how to navigate clinical settings. To these mothers, I'm beyond grateful. And one of these mothers can and should be acknowledged. Mayuko Ashida engaged in this research with me as an interpreter and informal cultural consultant. Her contributions were integral to this research. I began working with the Japanese sojourning community as an English language tutor in 2015. However, this was not my first time working with the Japanese community, as I had lived in Nagano, Japan as an English language instructor after undergraduate school. I came to learn in my work with many of Kentucky's sojourning Japanese mothers, caretakers of over 30 families, that many were ridden with worries, frustration, and confusion over leading their children through cross-cultural spaces. Healthcare settings, in addition to schooling, repeatedly came up in conversation. And this responsibility was often shouldered by them alone due to either the traditional segmentation of gender roles and or their husband's long days at work. As one mother told me, the most difficult thing about living as a foreigner here is going to the doctor. In some cases, the stress that these mothers experienced in navigating boundaries of language and culture resulted in mother anxiety and depression. As I began to learn about their healthcare beliefs, I learned to question in what ways our healthcare spaces were failing to support these mothers and the care of their children by not engaging in culturally and linguistically appropriate practices. This research is significant at both local and national levels from positions of health and social justice. At the local level, I turned to the Japanese sojourning population with whom I engaged in this research. In 2018, 4,515 Japanese lived in Kentucky. Many sojourners reside in Kentucky due to their relationship with Toyota. Key to understanding Japanese culture is the social convention of giri, or reciprocity, that is caring for others from one whom has received a debt of gratitude. Toyota's decision to award Kentucky the Georgetown Plan in the mid-'80s was a gift to the region as it created hope in the form of jobs, payroll, and tax revenues during a recession and double-digit state unemployment. Since its opening, 205 additional Japanese companies have followed Toyota, composing 63% of the state's foreign-owned businesses. And Toyota has invested over 120 million in local communities and 4.5 billion in the state. So I would argue that there's a moral imperative to reciprocate these gifts in the form of the provision of more culturally and linguistically appropriate care to the Japanese sojourning population. At the national level, the systematic neglect of culture and language and health has been cited by researchers and practitioners alike as the single biggest barrier to advancing the highest attainable standard of health. This is significant in that our country's population continues to become increasingly diverse, and globalization ushers in more sojourners. In 2015, more than 64.7 million US residents spoke a language other than English in the home, and 25.8 million were considered to be of limited English proficiency. Despite research, federal and state legislative efforts over the past 60 years, health inequities continues to grow. And researchers such as Weinstein note that health inequities research faces significant research and practical application challenges that need to be addressed in order to offer knowledge that can strategically and accurately inform interventions aimed at reducing or eliminating health inequities. Cited as reasons for this inadequacy include that today's healthcare settings still practice from Eurocentric normative frameworks, which lack recognition of accountability to differing worldviews. They lack flexibility and more appropriate and effective means to cope with sickness based in those differing worldviews, and they lack the ability to hear different but equally valid ways of communicating these perspectives. In addition, our research paradigms are rooted in monocultural frameworks, and they're often too devoid of community voice. The absence of community voice, or the act of studying on rather than with marginalized communities, precludes other ways of knowing and living and works counter to ethical healthcare delivery practices. In addition, research instrumentation has also served problematic in that other ways of knowings are not only operationalized as other, but that culture is crudely operationalized as unidimensional, meaning that we only belong to one, and bound to nominal racial ethnic categories. And last, there's limited research into how and why healthcare practices differ across cultures and how LAP populations define linguistically appropriate services. To address these issues of research and practice, the literature states that we must research in partnership with these diverse populations we serve rather than on them. Only with them can we expand theories to inform sustainable, culturally valid, and relevant programs which are tailored to the unique needs and resources available within their communities. So my research questions were first, how do the Japanese sojourning mothers define culturally and linguistically appropriate services? And culturally and linguistically appropriate was defined using the language of Office Minority of Health's class principle standard as effective, understandable, and respectful quality of care and services that are responsive to Japanese sojourning mothers' cultural healthcare beliefs, practices, preferred languages, and other communication needs. Secondly, what are the ways in which culture, gender, and language shape the health beliefs, behaviors, and experience of Japanese sojourning mothers in Lexington area pediatric settings? So due to the multiplicity of participant realities, definitions, perceptions, and experiences, I sought not generalizability, but rather some level of understanding in pursuit of these questions. So turning to my methods, I engaged in this research with 12 former Japanese sojourning mothers with whom I had already established relationships. My research was qualitative and phenomenological in nature as I sought to understand the experiences of these mothers in taking their children to the pediatrician. A total of 12 semi-structured interviews were conducted on Zoom in both Japanese and English. I engaged in the study using recommended practices in cross-cultural and cross-lingual research. And since the study was conducted across national boundaries, I complied with Japan's Act on the Protection of Personal Information. I also engaged in community-based participatory research, which is cited as key to culturally responsive research. It was from within the community that this research inquiry was born, and with them that I engaged in interviewing, member checks, data analysis, and concept development. Assisting me in this community-based participatory research was Mayuko, a Japanese sojourning mother with no ties to the communities the mothers I interviewed were a part of. She acted both as an interpreter, translator, and cultural consultant. Also noted as key to effective cross-cultural research, I employed pragmatic and constructivist paradigms. I use these paradigms to explore to a greater understanding of how versus what participants experience in taking their child to the doctor. And with this insight, I hope to prompt practitioners to consider how they can conceptualize and deliver effective, relevant approaches to healthcare delivery among the Japanese sojourning population. I then used the lens of intersectionality to come to a greater understanding of how the intersection of study participants' complex identities, Japanese woman, mother, former sojourner, non-native English speaker, shaped their healthcare beliefs and the lenses through which they evaluated their Lexington area pediatric going experiences. Data was then transcribed in the languages employed in the interview and then analyzing using the culturally responsive framework of a constructionist grounded theory. The focus of this method is to uncover beliefs and meanings through abductive analysis of data. While induction was primarily used for the understanding of mothers' definitions of culturally and linguistically appropriate services, I did use existing theory to understand how culture, gender, and language shape their definitions and their health behaviors. In the development of these concepts, I engaged Mayuko as a cultural informant in conversation regarding my findings to ensure their credibility. Together, we also conducted member checks, discarding any assumptions that were not supported by the mother's lived experiences. So how do Japanese sojourning mothers define culturally and linguistically appropriate services? Here are some of my findings. First, situated at the pinnacle of these Japanese sojourning mothers' healthcare beliefs was accessibility to pediatric services. Accessibility was framed by study participants as entry into the system through finding a pediatrician, concepts of timeliness, ease of appointment scheduling, and privacy. Unfortunately, these mothers cited several barriers to access to pediatric care while in the Lexington area. These barriers included not knowing how to find a primary pediatrician, the need to and the act of scheduling an appointment, predominantly over the phone in a second language, and interpretive services. While few studies have described the patient's perspective on barriers to medical interpretation and experiences in the clinical setting, mothers in my study shared that scheduling an appointment in coordination with the interpreter, the length and duration of appointments due to interpretive assistance, interpreter gatekeeping, and privacy concerns, given that sometimes interpreters held additional positions within the community, were all perceived as barriers to access to pediatric care. Second, the mothers defined respectful and effective pediatrician-mother communications as those which were kind and patient interaction, offered treatment options versus directives for their children, and enough information with which to make informed shared decisions. As one mother stated, the translation of which I will read and was echoed by others, there were doctors who don't listen to you, who just told me what they thought I should do. I don't know what to do because it's already hard for me that I have to deal with it in English when I'm treated in such an intimidated manner. So I would like the doctor to listen to me about what I'm worried about and then present me with a treatment plan. Mothers in my study cited that they had two choices if their healthcare beliefs conflicted with the pediatrician's recommended plan for their child: to either follow the pediatrician's recommendations, even if concerned with the healthcare plan, or to make independent decisions regarding their own care. The mothers also highlighted as culturally responsive the clinical interactions in which the pediatrician did not appear rushed and gave the mother many cued opportunities with which to ask questions. The mothers define linguistically appropriate health interactions as those which offer not only interpretive assistance, but also opportunities to communicate via reading and writing in English. This included access to online platforms through which to schedule appointments and communicate with clinical staff. They also appreciated written treatment plans and communications, which they could then translate, decode, and discuss with others within their social network after the clinical interaction. Also cited as key to providing linguistically appropriate pediatric services were professional and Japanese translation of registration and information materials such as child developmental progress markers. Due to perceptions of interpretive services as barriers to accessible pediatric care, linguistically appropriate pediatric service was defined by the presence of multiple on-site professional interpreters. Professional interpreters were defined as those who had a command of medical terminology, protected patient privacy, did not have another professional role in the community like that of a teacher, and could provide simultaneous direct translation. In regard to my second question, how do culture, gender, and language shape the health, beliefs, behaviors, and experiences of Japanese sojourning mother in Lexington area pediatric settings? I want to note that while axes of identities cannot be segmented, we tried to address this looking at through the lens of Japanese sojourning mother, Japanese patient, Japanese English learner. So I employed extant literature on the Japanese sojourning mother, the Japanese patient or health consumer, and the Japanese English learner to better understand how culture, gender, and language shape the beliefs, behavior, and perceived experiences of mothers I interviewed. So research indicates that Japanese sojourning mothers have lower levels of parenting self-efficacy and experience great degrees of social and linguistic isolation during their sojourn. One study documented that a quarter of Japanese sojourning mothers experienced minor psychiatric illness. And mothers in my study detailed this malaise. Many cited that they left pediatric appointments feeling hopeless or unsure of how to take care of the child, and that this impacted self-care via their own reluctance to go to the doctor while they were here. One said, I felt somewhat lonely and helpless. I didn't always come from a sense of relief. With my child, I didn't always come home with a sense of relief that my child would be okay, but rather with feelings of worry and insecurity. Of additional note is that common to mother sojourning experience is dependency on the husband and his company's social network is the primary reference group for support. However, this was cited as problematic by both mothers in my study and other studies, as this network is rooted in social obligations, which exert a level of social control that causes distress and disables help seeking. In addition to this, I analyzed the mother's beliefs, behaviors, and experience through Japanese patients. So the mothers in my study perceived the primary care physician, appointment scheduling, and the securing of interpretive services as barriers to accessible health care for their children. So many attend a little clinic or bypass language concordant care for immediate access to health services. And these perceptions and behaviors are not surprising given that Japan's universal health and free access infrastructure and the country's use of multi-provider centers, which discourages patients from using a single provider. However, this does have implications for continuity of care. In addition, looking at normative pediatrician mother communication in Japan, Street's linguistic model of patient participation in care posits that patients' engagement in clinical encounters is correlated with the belief that in the appropriateness of the participation. So mothers in my study felt uncomfortable questioning a doctor's healthcare plan for their child and finding space within the clinical interaction to engage in shared decision-making. And the vertical hierarchy and traditional patriarchal culture of medicine in Japan, which was cited by mothers in my study in the literature, may have contributed to some of them not feeling comfortable asking questions. Lastly, explored how language shaped their experiences. The average TOEFL score for Japanese test takers is one of the lowest among countries in Asia. Reading and writing skills, keys to passing prestigious university entry exams, have been prioritized over communicative English skills by both students and teachers. So as illustrated in my study and documented by considerable research, limited language proficiency is a significant cause of stress of Japanese sojourning wives and causes medically significant communication errors. So this explains why written communications were often cited as key to definitions of linguistically appropriate care. So culturally responsive research doesn't end once findings have been arrived at. How, where, and to whom research is disseminated must be determined in concert with women who participate in the study, and we continue to have this conversation. I continue to be engaged with this community in my current work within Kentucky's bourbon distilleries, as the majority are owned by Japanese businesses. And my work now centers on their health as related to occupational safety. Thank you so much for your time today, and I look forward to conversing with you about this research.